Esteemed colleagues, a very good morning. Everybody knows globally that there is a consensus insulin remains the drug of choice. But at the same time, hypoglycemia remains a big concern, and everybody is afraid of pricks. So, is there any way out? Physicians are looking for that, patients are looking for that. But what an ideal oral agent should have, it should not cross placenta. And even if crosses placenta, it should be without any side effects. Like hypoglycemia should not be there, hyperinsulinemia should not be there, and of course, it should not be teratogenic. The drug which has been studied in pregnancy is mostly metformin and glyburide. So, metformin is an oral biguanide used extensively in the treatment of type 2 diabetes since decades and for many years in insulin resistant polycystic ovarian syndrome patients. However, its use in the pregnancy has been so far limited. It works increasing absorption in the gut, reducing liver gluconeogenesis and increasing peripheral insulin sensitivity. And recently, global evidences have concluded that metformin is safe and effective in GDM management after 20 weeks, and evidences are coming up in favor of its safety in early pregnancy too, and that is the big news. So, this is the MIG trial, metformin in gestational diabetes. 750 women, GDM at 20 to 30 weeks, divided into two groups, one group metformin with supplemental insulin if required, and other group on only insulin. Key outcomes were neonatal hypoglycemia, respiratory distress, requirement for phototherapy, 5-minute Apgar score of 7, or premature birth. And big news is that it was similar in both treatment groups. Now, MIG diabetes trial, metformin group was not associated with increased perinatal complications as compared to insulin. And what was very important, obviously the women preferred metformin to insulin treatment. And the outcomes were non-inferior to insulin. And what was on the positive side? Lower total and late pregnancy maternal weight gain. And yes, it crosses placenta, but despite this fact, there was no fetal hypoglycemia, but slightly increased risk of prematurity by barely 1.7 days. So, but it has shown no benefit in preventing a spontaneous abortion in PCOD cases. And this MIG study has changed practice and guidelines in many countries. Now, MIG tofu, that was a big concern, metformin in gestational diabetes, the offsprings follow up. What the offspring suffer after their birth. Metformin and insulin, mostly in the early childhood, there was not much difference, but in the mid-childhood, there was obesity problem with the offsprings. But more studies and longer follow-ups are needed. It seems metformin may interact with fetal environmental factors to influence offspring outcomes, low birth weight, and postnatal catch-up growth with cardiometabolic complications. Now, this is MITI trial, that was GDM trial. This is pre-GDM trial. In this prospective multi-center international randomized parallel double-masked placebo-controlled trial, the women were divided into two groups. One group got only insulin and other group was given supplemental metformin. Women were eligible if they had type 2 diabetes, were on insulin, had a singleton viable pregnancy, and were between 6 to 22 weeks plus 6 days gestation. Now, a very important thing was there was no difference in the primary composite neonatal outcome between the two groups. It required less insulin, gained less weight, metformin group had fewer cesarean births, and there was no significant difference between the groups in the hypertensive disorders. Women weighed less, and we have already talked about that, and fewer weighed 4 kg or more. So, the chances of macrosomia, which is a dreaded complication, that was lesser. and no significant difference in cord C peptide between the two groups. So, can we give metformin in early pregnancy? This was the study, recent meta-analysis by Zheng et al., which studied 13 studies. Metformin use in first trimester did not seem to increase the risk of major congenital anomalies in offsprings with pre-GDM or PCOS. Now, this is a big news that in European work sharing procedure, glucophage was approved as the first oral anti-diabetic medicine used safely from conception to birth. The approval was granted on the basis of Merck's own safety cohort study. This approval addresses a significant unmet medical need as the prevalence of hyperglycemia during the pregnancy is rising worldwide, currently at 1 in 6 births. Glyburide, firstly it was assumed that glyburide did not cross placenta, and there was a sense of elation in the medical community for this. But later on, when the recent diagnostic techniques like liquid chromatography came, then it provided that glyburide can be found in umbilical cord serum by using a sensitive liquid chromatography test for determining at a sub-Ng level, confirming that glyburide does cross placenta. Umbilical cord levels up to 70% of the maternal levels were reported. So, and there was increased incidence of fetal hypoglycemia and macrosomia. Glyburide may be considered if proper insulin storage or SMBG facility is not possible, or if the patient is in a refusal mode, severe needle phobia is there, and there is intolerance to metformin as well. A Carbo's list studied, just mentioning this could be a future thing. Less than 2% of the dose is absorbed as the active drug. 34% of the metabolites are found in the systemic circulation. Doses of up to 9 to 32 times in the human dose were not teratogenic in pregnant rats or rabbits. There are limited but reassuring small studies to show that good glycemic benefits and non-inferiority versus prandial insulin is possible, and gastrointestinal symptoms will be frequent on this. But bigger studies are needed before we can comment on this. Thank you. No, this is the last slide is very important, that FDA still doesn't recommend any oral drugs. ACOG, NICE and others advocate in selected cases, and in those cases where the patient will outrightly refuse insulin, you don't have other way out, and out of that metformin is preferred, and glyburide is indicated only when if there is intolerance to metformin. Thank you so much.